In this video, we will quickly review, because you've seen the classification of epidemiological study types, so quickly review a few of them and focus on cohort and case control. Analytic study designs are all the ones that are, to put it simply, not descriptive. And under analytic, we separate observational studies from experimental studies. And in experimental studies, we know that the key aspect that helps us identify them is that the researcher administers treatment. In all the observational studies, the researcher observes people choosing which exposure they will be self-administering. So here's a visualization. So this is not randomized control style trial. So this is, we can call it, self-administration of exposure. Okay, so not randomized control trial. The experimenter does not choose who gets to take electronics before bed. All right, and usually, so this time piece, so that we're looking at cohort studies here, which are the most similar to experiments. And so there's some sort of choice to be exposed to electronics before sleep, period of time, and then we look for evidence of insomnia, yes or no. Subtypes of cohort studies. So we have dynamic, fixed, and closed cohort studies. And these has to do with the population, so the source population, the population that we're going to be following over time. And so we've looked at these before. So these dynamic and fixed are not news to, and so these really help us choose whether we're going to do incidence rates at the end or cumulative incidence. Other types of cohort studies we see are two-group, where we look at presence or absence of exposure. However, we know most exposures are not that way. And so we have in smoking, yes, no, it doesn't make sense at all. So we would change that to non-smoker, occasional, pack a day, whatever. So we would have, instead of 2 categories of exposure, we might have 3, 4, 5 categories of exposure. And so that's what we're looking at here, multi-level. Okay, so that's the reason that we have those different types. And we look at prospective, retrospective. This is the one that's going to be the most difficult to identify, and ambidirectional. And so prospective is the most simple one because it's very similar to what an experiment would look like. Retrospective usually requires looking back either through a survey about previous exposures or some sort of logs or other evidence for previous exposure. And here's a visual from our textbook. And so this page number is from the 2nd edition, so your 3rd or 4th editions will have a different page number. But the idea here is that exposure predates the start of the study. This is the start of the study. Sorry, start of the study is here, and exposure is going on. Retrospective, the exposure took place, the disease took place, and then the study starts. And then ambidirectional, where it's somewhere in here, right? So it could be, we usually see the disease, see evidence of the disease, and then we look back for exposure and look forward to see how the disease manifests itself. What does a retrospective cohort look like? Here's an example. So you start with a cohort of people and find out whether exposure and disease happened at some point in the past. So example, we have 120,000 people. Were evaluated for exposure to thimerosal, and then we looked for the researchers looked for neurodevelopmental disorders. So they did not start with people who were exposed and compare them to people who were not exposed. They did not start with people who sorry, who had neurodevelopmental disorders. But what they did is they started with a group of people and then looked back retrospectively for disease and for outcome and exposure. So, problems, weaknesses, no randomization, so there's no assurance of equivalence at baseline. So that's, we mentioned that already in class. No blinding. The researcher knows who's exposed and who's not exposed. And loss to follow-up, again, over long periods of time. Not in the retrospective studies, but in the prospective studies. There will be lots of, the population will be dynamic, hopefully not too dynamic. Another weakness is choosing a good comparison group. So this is the best. So this is the #1 way of doing it, and there's a lot of cohort studies like this, and they would not be considered weak because you have the source population. Everybody is studied within one group, and then exposed are within that group. So the Framingham study, which is described in the textbook, is a good example of that. And then we get weaker as we go down. Weaker and weaker. So the general population, we have a cohort of individuals without exposure. So asbestos miners in Quebec compared to residents of mining communities in Quebec who are not miners. Okay, so we find another group. So we have two groups that we compare that are relatively similar. And then a comparison cohort is a cohort who is not exposed but similar. So we look at asbestos miners versus salt miners to see if asbestos mining exposure leads to some sort of poor health outcomes. Typical sequence of a cohort study. Sampling, typical. Sampling, recruitment, collecting data, and analysis. Straightforward, very similar to experimental studies. So not much to think about there deeply. Where do we get exposure information? Medical and employment records, questionnaires. So this is for retrospective studies. Questionnaires and interviews, that would be for prospective studies. Direct measurements, as again for prospective or maybe cross-sectional. Though cross-sectional studies and cohort studies, we want to distinguish between them. And then we monitor groups where they check in every once in a while, and they fill in questionnaires or we do direct measurements. Data collection, we've mentioned this already, so medical exams, so that's direct observation, questionnaires, indirect observation, physician, hospital, so that's somebody else doing the direct observation, and death certificates, which delineate cause of death. Case control, these are a lot more tricky, and so that'll be the most challenging part of this classification that you're going to be doing. And they're close relative, but they're different. So it's like the cousin from another country. We don't really know. We start with people who have been identified, so retrospectively with a disease, individuals with outcomes. And you'll see this shaded here because in your handouts I have, this was called source population, but that part was confusing. So what we're going to just look at is just focus on that. We start with a group of cases who have the disease, and then we find, so this arrow here says we go and look for. So these are two separate, almost two separate data collection streams. And researchers start with the cases, look for appropriate controls. So these controls have to somehow be similar to the cases. And then we measure exposure. So this is a measure of exposure. And again, that could be through survey, through direct measure, through medical records, and so on and so forth. Here's an example. This is exercise 5D. So if you would like to pause this and open that up to go through this with me. So we have question, does foie gras, this fancy food, cause gallbladder cancer? And so we have 150 patients with gallbladder cancer, so that's these guys here. So they're identified, so that's a fairly rare cancer, so we have to go out and find a bunch of controls. We don't know how many, right? We can find how many we want. We can find, in this example, it's 600, but it could be 1,000, could be 200, could be 150, could be 50. So there's usually we want to get about 4 times more, so 600 would be appropriate. And then we look for exposure. And this is outcome. All right, so step 1, step 2. And we fill it out a contingency table just like we would for a cohort study. We're going to look for the rates. You see, this is the tricky part. This is the independent variable, and this is the dependent variable. So exposure, and this is outcome. But the outcome, this number, we started with that step 1, right? We started with 150 patients with gallbladder cancer. That's the total of this. But we don't have this. This is that number sign, number sign, number sign. We don't know how many. So we have to go out and get these. Okay, in this case, we went out and got 600. So that's 600. So that's that step 2, right? Find 600 individuals. And then we asked them about exposure. So we had 277 out of 600 said yes. The problem is that these numbers, right, the relation between these numbers, 150 and 600, were chosen by the researchers. So this rate of disease, oh, this is a mistake here. That should be 150 out of 750. Okay, is not accurate. So now what we do is, so we can't calculate relative risk directly. And what we're going to do is we're going to just calculate. So these are the numbers. You can go through and calculate them. So what we're going to do, so I'm going to take a break from this for a sec, and we'll talk a little bit about case control studies before coming back to these calculations. When is case control preferable? Well, when the outcome is rare. So gallbladder cancer incidence is 1 per 100,000. So if we get 50 or 150, you need to get a lot of people in a cohort study to get that many people with the disease. So we start out with 150 disease. That's really cool. If we have a clinic that specializes in that, and then we have to go out and find people without gallbladder cancer who are similar. So diseases also that have long induction or latency period, again, cohort studies people over a long period of time prospectively. And so case control, which kind of grabs a bunch of people who have the disease, who have been diagnosed, and we look back. And then new disease, something we don't know much about. So it gives us a first look at possible exposures that predict the disease. Typical sequence of case control, again, sampling and recruitment. So this is step 1, step 2, that described earlier. And then we go out and collect data. So this is the asking, once we have recruited cases and controls, we look for exposures. And often it's multiple exposures. So in the examples we'll be giving you, there's only one exposure, but you can imagine we'd look for multiple exposures that could cause the disease. And analysis, we do not use relative risk, we use odds ratio. This is, yeah, so you can read through this. There's not much to think about there, not much complex there. And now we do look at the calculation, which you have already looked at. So I will skip through this quickly and go to the calculation of odds ratio for the problem given. And so the odds ratio here comes out to be 1.168. And we see that really there's not much to worry about there with foie gras eating. So go ahead and eat how much you like if you're worried about bladder cancer. And now here's another quick example for you to try. 149 women with spontaneous abortions. So this is these are cases, and the controls down here, right? So we start with cases, then we get the controls, and we move on. Oops, this should have been over here. And so then we're getting the rates. So I'd like you to draw a quick contingency table, pause it if you like, or look at the solution as we go along. So it's good to get the relation between this and this. So make sure to practice doing that sketching out, because that's like a technical skill that you have to practice. And so now we go odds of spontaneous abortion among exposed. We get the odds, and then we calculate the odds ratio. And we get that women with a history of induced abortion were 1.3 times more likely to have spontaneous abortion. Thank you for hanging in.